Hello, everybody, and welcome to another episode of the Surdentity Podcast. I am your hostess, Elizabeth Dewar Anthony, and I am thrilled to have with me today a leader in thought and action on the temporomandibular joint, Dr. Jay Levy. And, Surdentity, serene dentistry, is about not traumatizing the people in our care. And so many of patients who present with challenging behaviors that dental professionals like to complain about have TMJ problems. And those TMJ problems come from grinding the teeth, and that comes from airway issues. So, my message to my fellow professionals is if you can learn to spot the symptoms of airway dysfunction in your patients, you're going to have a much better understanding of why they're acting the way they're acting. And empathy leads to understanding, understanding leads to serenity, and serenity leads to a better interaction for everybody. So, very happy to have you on here this morning, Dr. Levy. How are you?
I am great. It's Friday. I don't usually see patients on Friday. I just come in for things like this, or I'm in the office to do a whole bunch of lab work, model work, that kind of thing. Um, yeah, I'm interested in talking to you. I just took some notes about what you're saying, and which sort of makes me want to, open the conversation with a couple of points. Okay.
Absolutely.
Um, First off, you said TMJ.
Mm-hmm.
Excuse me. I know you're low key and kind, but that's nonsense. Okay. The TMJ is the joint of the mandible, and the atlanto-occipital joint is the joint of the maxilla. So when we open wide, your head moved up. Okay. Studies, Erickson and Zafar, they put trackers on the skull and on the chin. And when you're chewing, 80% of the motion is mandible, but 20% is the maxilla. One of the reasons why TMD,
Mm-hmm.
temporomandibular disorders and facial pain are so poorly understood is the anatomy isn't really right in most of the discussions. Okay.
All right.
And airway is something that's totally related to all of this. I wrote a couple
Mm-hmm.
of chapters for Daniel Tamimi's textbook, specialty imaging of the TMJ and sleep disordered breathing. It's only about 100-pound textbook.
Wow.
So, and I've got, illustrations of fascia and tensegrity and all these other concepts that I lecture on. Now I got my feet up on my desk. It's okay.
Good for you. Good.
My best way to talk. Okay, so it's TMJ and AOJ. Well, we'll get back to that. Don't let me
Yeah.
forget to get back to that. But I want to get to you and what you're talking about. Okay, not traumatizing patients
Mm-hmm.
and that sort of thing. And empathy and understanding and serenity. My dear friend Dave Carson's a dentist here at OHSU. You might actually want to interview him on empathy. He gives lectures on empathy, and he teaches at the dental school as well. He teaches the residents, OHSU. Super important. About a dozen years, I gave my first lecture in Germany, and I met this wonderful pediatric dentist named Petra Schwarz.
Mm-hmm.
And I met her. She was in my lecture audience. I was giving a 2-day course, and it was just amazing. What she had to say was crazy, good.
Mm-hmm.
And I, um, that evening, I said, you've got to meet this woman, this dentist. She's amazing. And my wife like rolled her eyes. Another boring dentist. She doesn't like to talk to about dentistry. We don't talk a lot about dentistry. So within 5 minutes of meeting Petra, she started crying. And she's this amazingly gentle, empathetic woman. I think the world's best pediatric dentist, and I know some very good ones. Um, and I just lectured in Germany this year again for a couple of days in Kempten, and I met her after 12 years, and she's the same. I mean, we stayed a night in her house in a small town, and she taught me a really big lesson in practicing dentistry. And I'm not a great businessman. I think I understand the chewing system better than most people do. But I have a mission statement, and it's one word. It's called love. You know,
Yes.
okay. I love my patients. I love my work, and I work hard to make my patients take care of their teeth and love themselves. Okay. Petra told me that these kids would come to see her with rotten teeth and their teeth would hurt and they'd hate their teeth.
Mm,
And she would teach them to love their teeth and love themselves. And that's what I do. You know, most of my patients um, love themselves and take care of their teeth. They may have other aspects of their life in disarray, but when they come in for recall, 99% of them um, just, their teeth are immaculate
mm-hmm,
and their gums are immaculate. And
mm-hmm,
I myself show them how to brush and floss repeatedly until that's the reality. It's
mm-hmm,
really rare. I had somebody a few days ago who I've been working on for years and I couldn't really get through. And, swollen gums in one spot or two spots, three spots, and just really not cleaning well. And, you know, I think the underlying problem is love. It's family issues. It's history of you know things like alcoholism in the
yes,
family,
yes.
and so there's all this damage that's running around our society and our population, and we're just dentists or just hygienists, and we're practitioners, and we get to meet people at 1 or 2 or 10 or 20 points of in their lives, and we do have a chance to make a difference. And it's just more than teeth. It's so much more, you know. Um,
Mm-hmm. You know, the,
uh,
the the oral cavity is the most one of the like the most intimate area of the body, and it's mental, physical, and it's spiritual. And I don't ever want to be part of breaking someone's spirit.
no, no, it's. I have many patients coming to me, and it's like they're traumatized from the past, but
Mm-hmm.
they they say, I love you, but I really
Mm-hmm.
don't love dentistry in
Right.
general. And you've got to try, and me in particular, I'm not fast. I take a long time doing things, fillings, and I solve problems that very few people in the world can. And I have patients coming to me from all over. Just this week, a lovely lady from Hawaii came in, and it's 3,000 miles away to get to Portland, Oregon. Uh, and while she's here, coming back from lunch, another lovely woman from Austin, Texas, she's got 4 kids, and she's going to come to see me in a couple of weeks. Um, because there are problems with pain and bite and
Mm-hmm.
grinding that they don't understand,
Mm-hmm.
and they haven't found anybody to help them. And the problem is, it's basically something that you're dealing with directly. So I applaud you for it. You're dealing with love, you're dealing with
Mm-hmm.
compassion, you're dealing with empathy. It's, we have this industrial model of healthcare in this country where you crank out one patient after the next, and then dentists do that and they get messed up by HMOs and PPOs and insurance, and the fees get knocked down. And, you know, my mission at this last part of my life is to teach dentists how to do dentistry. I'm a
Mm-hmm.
general dentist, and to them, what I do sounds very, very complicated. To me, what I do sounds very, very simple
Mm-hmm.
when principles are known. But you have to, as a dentist or a hygienist, step aside and look at the underlying science behind these issues. I became somewhat of an expert on these issues just because I spent my life deep diving into various subjects that were not traditional subjects. I mean, I did like a 5-year postdoctoral fellowship in neurophysiology at OHSU when I wanted to understand how teeth feel things. Okay.
Yes. Wow.
Mechanosensory systems. In recent years, Dania, I'm in the forward of the dedication of this book, because I contributed to a few other chapters besides the 2 I wrote. She introduced me to fascia, and then tensegrity, and these are occlusion topics. One of my chapters, it was on tensegrity and airway.
Mm-hmm.
Um, we are, as humans, tensegrity structures. And what does that mean? You know, hang on just a second. You're gonna have a blank second. Okay.
I'm learning a bunch of new words today.
Yeah. I do my new patient exams. They're 2-hour visits. And I hang out in the waiting room at least for the first half an hour with patients. And I pull out my toys, you know.
Mhm,
This is a tensegrity toy. It's a squish toy. You can buy it for
mhm.
10 bucks on Amazon. And this is like the human body, except the teeth are in there somewhere.
Right.
So we're tensegrity structures. Tensegrity is a concept that was coined by Buckminster Fuller. And he was an architect and engineer, and he invented geodesic domes. So a sailboat mast. Do you sail at all? Have you been sailing on in
No.
Rochester? Okay. So those
I
tall
should.
masts. I love sailing. Those tall masts are held up um, because of the cables holding them up,
Mhm,
and they're very slender. And so the mast is called a discontinuous compressive element, and the rigging is part of a tensile network.
mhm,
So tensegrity structures have that. All these, you know, rods connected by flexible cables. And
mhm.
it's very robust. You can sit on it, it'll come right
Yeah.
back to it. Very strong. This one, these are elastic bands, they're not cables. But suspension bridges are tensegrity structures, but the human body is a tensegrity structure. We've got bones,
Mhm,
discontinuous compressive elements, and teeth. And we have ligaments, which is part of this fascial web that goes from head to toe.
mhm,
In the middle of all this, we have organs and bones, even muscles. You know, when you contract a muscle, it couldn't pull your arm unless you had fascia. Fascia goes through the myofibrils and attaches the bones together. And and there's this thing called when you hold your hand out, your fingers just naturally curl. Hold your hand up too. This is participatory. Look at your fingers, they're curled. Now
mhm.
straighten your fingers. Straighten your fingers. Active muscle tone. Relax, passive tone. Make a fist, active tone. Relax.
Wow.
So fascia is this tensile element that has a certain degree of springiness to it. It's got a spring constant. It's viscoelastic. There's fluid squishing around the tissues, and you may not come back out straight right away because the fluids have to sort of reorganize through the fascial planes. You
Mhm,
take apart a chicken and you tease through the layers of fascia.
mhm.
So that's a missing element in the world of occlusion, and it's actually, I think, a missing element in the world of airway because it's not incorporated well enough into
Mhm.
the larger audience of airway-centered dentists, which is happening, which is
Mm.
wonderful. And it's not the full tensegrity picture isn't included often in the tongue tie release aspect, for instance, or
Yeah.
and the active muscle tone, the fact that teeth are sensors driving active muscle tone, jaw reflexes, avoidance behaviors, head posture, that's not in it's not in a lot of the various decision-making processes that we have. I lost my train of thought a little bit there. I tend to go in different directions. This is a sort of a wide-ranging conversation, but tensegrity holds the airway open. Okay,
Mhm,
you've got bones, you've got the mandible and the maxilla, and you've got the hyoid bone.
mhm.
Okay, if you hold the jaw forward, this is another tensegrity example, hold the jaw forward and then release, it pops back.
Yes.
Okay, you've got the stylomandibular ligament, the sphenomandibular ligament. Those are elements of passive muscle tone,
Mhm,
fascia-driven posture. The key to establishing a stable occlusion is really, really simple. It's allowing all the teeth to touch when the mandible and the maxilla are centered with passive muscle tone. And then when the teeth touch, they're so sensitive, they have to touch and not drive the jaw into different positions and not drive the head into different positions.
mhm.
So, I mean, the TMJ isn't a pinned hinge like a door hinge.
Right.
It has different axes. So if you look straight ahead and very gently touch your teeth together, you don't have to touch it. Just touch your teeth together.
Mhm.
Notice where they touch. But if you look way up at the ceiling, and very gently go to close, you'll generally notice that the teeth are touching more to the back. Try that. And then when you look straight ahead, it's like, oh, they touched the way they were touching when I was looking
Yeah.
before. And when you look down, it's more on the front teeth.
Yes.
And Pete Dawson, and he was learning from me just before he passed a couple of years ago, that the jaw position and so-called centric relation depends on head posture because we're tensegrity structures. When you're looking up, the the pharyngeal I'm sorry, the mylohyoid muscle, mylohyoid raphe goes to the hyoid bone, goes down to the sternum. It takes the chin and pulls it back, and the condyles seat further in the eminence, in the TMJ, and so you're on your back teeth. And when you're looking down, you're more on your front teeth. Now, Bukowski was a physical therapist who wrote a paper in 1989, and he called that phenomenon the sliding cranium theory. So we chew with two jaws, and there are really six joints of dental occlusion, at least proximate. You've got the TMJs with the lower compartment and the upper compartment, and the atlanto-occipital joints. So, and studies show the neck muscles are chewing muscles. So if you open wide, you've got to use
Right.
muscles in the back of your neck, the rectus capitis
Yep.
posterior minor major. And some of those muscles, like the rectus capitis posterior minor, are just loaded with muscle spindles. And those muscle spindles are there mostly because they're connected to vision. When you're walking through a field and you're looking at things, you're trying to keep your gaze steady so you can locomote nicely. And the normal function is that. But when you have a bad bite, those muscles are going to be overloaded, using it for adjusting your head position. So the target zone of the maxillary teeth are just right so the mandibular teeth can meet them correctly. And so those muscles get overloaded, which is why serogenic headaches are very, very often related to bad bite issues, things like that. You said something else about grinding and clenching from airway issues. Well, that's one part of grinding and clenching, and I don't even know what grinding and clenching are. I mean, they're behaviors. I don't know what TMD is. It's this wide definition of disorders around the face, around the jaws somehow. It's just, we're dentists, we're hygienists. We deal with the teeth, but tooth alignment has such a profound influence on things. Have you ever ridden horseback? Ridden a horse?
Yes, I have a couple
Okay,
times.
so it depends on your philosophy of riding, but if you have a horse with a bit and a bridle, what do? You have this metal thing between the teeth, and you pull a little here and you pull a little there, and a 60-pound girl like my daughter, this is way back, she, she can control a 1,200-pound horse
Yeah.
with a little force here and there because there are so many reflexes associated with teeth. And, teeth are sensory organs. That was the crux of my research at OHSU. I published a few papers in neurophysiologic journals about that. When I wanted to understand the function of teeth as sensors, I did a postdoctoral fellowship in neurophysiology at OHSU, and I started a lab and I vibrated teeth. And you might ask, well, why are you vibrating teeth? Well, the sense of touch, when you touch an object, if I touch, I know this is a model of some teeth, if I rub my finger on one of the surfaces, I can tell how smooth it is because the movement generates vibrations. Vibrotaction. When you pick up objects, when you bite things, you're getting a sense of how hard they are, how much resistance, what's the texture. And the teeth as sensors, they adapt to bad bites. And what orthodontists that don't know about occlusion do, they put the teeth in positions and they don't function well. And patients are trying to move their jaws around to get their teeth to fit together, but it's upper and lower jaws, so they're moving their necks together too. So most orthodontists just line teeth up like picket fences, picket fence, and they don't actually relate to each other. And then they say, oh, you'll settle in, and God willing, inshallah, they'll settle in, fairly comfortably, but they don't. And so many people in our culture have malocclusion, and so many patients start breaking down their teeth. And this patient who came to me from Hawaii this week, I took photos and we're going to make her an occlusal splint. But when you look at the photos, these high definition, macro photos, it's like, my God, these dentists, they had fidelity in making good margins, but they didn't know where to put the bumps on the teeth. They didn't treat her like a system. Now,
Mm-hmm.
I'm a dentist who does systems thinking. Now, on top of that systems thinking about how the chewing system works, that's what you do. You're talking about compassion and how does the overall system work? I mean, that's a piece of it. One of the things that I noticed um, in my work is patients just feel good when you get their bite right.
Yeah.
And things change. This is for you. Yesterday, I bonded 10 teeth out of a dozen teeth and adjusted the bite on a patient who had ortho. And she noticed something and she wrote, I've seen you seen on Facebook, I write these sticky notes, right?
Yes.
And so there's patients, and they tell me some things, I write it down. And then I may do a post. And I used to stick my tongue between my teeth until they were fixed. Now I don't have to. She signed her name. Um, so you've got oromyofunctional therapists training people to do things that they don't necessarily have to train them to do if they had a good dentist that understood occlusion. All of a sudden, that problem wouldn't be there.
Hmm.
But you have to think about what the occlusion is. So, I mean, I've got photos, and she showed me a photo. I don't want to show you her photo in public, her face, whatever. But I can show you her tongue, and you can see the tongue going between the teeth.
Sure.
Tongues do damage to the teeth. They get mobile in the front. I had a dentist in here last week, and his teeth are mobile, and his bite's unstable, and he pushes his tongue against his teeth.
Sure.
You put an anterior jig in the mouth, and he doesn't push his tongue against the teeth anymore. I got videos of patients, and in my courses, I show these videos. I don't want to show videos to this sort of public arena. I don't want to,
Oh, right, right.
HIPAA rights and things like
Yeah,
that.
right.
But to dentists and to people who sign up for my courses, I show lots of videos and I talk about patients. So tongue behaviors change, swallowing changes. I have some nice videos of a patient who came to me referred from an oral surgeon. And some of my slides show I've got like 40 pieces of paper, referrals from various specialists, neurologists, and this lady's on a fentanyl patch. And the most recent diagnoses for her terrible jaw pain and lancinating pain was to a coronoidectomy, the coronoid process of the mandible to
Mhm.
shorten it. So here's a cheap plastic skull, and so here's the coronoid process, and they were going to cut that down because they thought it was getting in the way of motion. Well, what they didn't notice was that this condylar process was way short. And
Yeah.
so I saw her cone beam CT before I ever saw her. And this was two dentists, and one of them was really quite famous. I won't mention names, but they didn't see. I mean, that's a big problem in dentistry, not seeing issues. I learned this in dental
Mhm.
school from an obnoxious operative dentistry teacher. Page was his name. He told me to like stare in a cavity for like an hour and see it, really see things. But they're not seeing that the condylar process was short. If the condylar process is short, that means the patient has to have an anterior open bite, unless it happened very slowly over time and the teeth wore down or were lost.
Mhm.
So I knew this patient was struggling with an anterior open bite and pain. And
Mhm.
so the first thing I did was have her put a piece of cotton in her mouth, a little small piece of cotton, a cotton pellet, okay?
Mhm.
And just, something, like that.
Yep.
Okay, this is a tissue, but instead. And I asked her to, without the cotton in her mouth, drink water. And just gave her a cup of water. And I have this on video. And to drink the water, she'd have to do this in
Yep.
her
Yep.
face, with her whole face. And then
Yep.
I put that piece of cotton between her teeth, and she says, just put it between and swallow. And she takes her cup of water and she just
Just swallow.
eyes are open.
Right.
No facial expression. And this is actually I need to write a book chapter or a journal article on this. So when patients have anterior open bites, um, they don't want to overload their back teeth.
Yes.
Okay. And so the masseter and temporalis muscles are huge, strong muscles.
Mm-hmm.
And so instead of using those muscles to close, so in order to swallow and propel the liquid down the throat, you've got to clench, elevate the hyoid bone, and and contract the pharynx, close off the airway, but you clench with about 20 pounds of force. But if you don't have a stable way to bite, you bite your tongue, you tip your head, because if you tip your head down, biting more on your front teeth, you can slide the condyles down the eminence. This is what I was alluding to when we were talking about tipping your head and biting in the front. You change your posture to get more teeth to touch, but it still wasn't enough for this lady. And so she's recruiting her muscles of facial expression to basically close the jaws together.
Yeah. Yeah.
With the front of the face.
Yes.
And you see, and they're using the orbicularis oculi muscles and all these other muscles that we didn't study in dental school.
Right.
And I have books, with muscles of, uh, anatomy of facial expression, and we're recruiting muscles that are not.
Then we're not supposed to be. Right.
Right. And so, but if you just put a piece of cotton between the teeth, they don't recruit them anymore. And they tell me things like life is good. Now, you can't live with a piece of cotton between your teeth, but you can live with a properly adjusted occlusal splint. And then they do great. Okay. But now you're just putting a new discontinuous compressive element, the wedge of plastics. But this is nice to do in my office. I can just pull out all this stuff.
Right, right.
This is just generic. It doesn't fit me, but
that
changes the position of the lower jaw and the upper jaw. One of the things it's going to do is it's going to actually tip the head up just a little bit. So if you actually look up, did you ever take CPR?
Of course.
So what do they teach you? Head tilt, chin lift, right?
Right.
What does that do?
It opens the airway.
Yeah, because of fascia and tensegrity. Okay.
Right.
So, in my chapter in Tanya's textbook, I talk about 4 fascial strings. Okay. So the airway is held open by 4 fascial strings. You have the mylohyoid raphe, you have the 2 pterygomandibular raphes, and you have the pharyngeal raphe. The pharynx hangs from that. And the pterygomandibular raphe basically is the buccinator muscle in front and the superior pharyngeal constrictor in back. And so if you do rapid palatal expansion, you're going to make things wider. So you're going to open the airway. If you do BSSO, mandibular advancement surgery, you're going to pull the mandible forward, and you're going to pull the mylohyoid raphe and pull the hyoid bone forward and open the airway. I mean, the hyoid bone is like a mini mandible. It's holding the airway open too. So the position of the hyoid bone and airway is critical. Now, Joseph Yosefian, my friend and orthodontist up in Seattle, likes to call himself a pharyngeal orofacial specialist. And what he does, he calls teledontics. You could talk to him once on your podcast. I'm sure he'll be happy to talk to you. Joseph Yosefian. Okay. And, we expand, or he expands faces. I'm kind of the quarterback. I get the cases started and I finish the cases, and I diagnose things that are going on. The only reason why I can diagnose all these patients is I spend time with them. I spent time looking and reading and researching my own and reading other people's research to understand this and to put this in intelligible ways. But so here, the reason why I bought this $30 skull, it's amazing what you can buy for $30, is because here's a little fake disc. Okay.
Yes.
And with the disc there, everything meets just fine.
Yep.
Okay. Now, I spent an hour cutting this disc out. So here's the disc. I put it on the counter. And then what happens is the fascia will pull things together. And so if you lose the disc or you lose height of your condyle, what do you get? What is that?
It's uneven.
An anterior open bite.
Yes.
It's a unilateral anterior open bite. Now, if 2 condyles break down, you'll get, an even anterior open bite. But if only one's broken down, it's there. So the patient's really unstable, and they destroy their back teeth, and then they throw their tongue between their teeth to try to stabilize things when they're swallowing. But if you make them an occlusal splint that fills in the gaps, then they have this altered axis, and they can swing on that altered axis, and they're happy as clams, and they're comfortable. The reason why I help people and they travel 3,000 miles to see me is I understand that. And darn if I can't get more dentists to figure out how to practice this way. I get interest, but I don't get interest enough to get into deep diving into all of this. So I need mentees. I need students. And as a friend of mine who's a wonderful dentist from Romania said, I need disciples. I need dentists that really want to understand this, and hygienists and other, allied professionals and physical therapists. I have, PTs that come to my courses periodically, or I have an online 16-hour Occlusion 101 course. You can find it on my website. And I talk about the science of occlusion, the basic science,
Mhm.
physiology. Physiology is two big chapters. It's like 4 or 5 hours, and neurophysiology. And is how do we get here? We have this worldwide pandemic of collapsed facial form, which wasn't there in Aboriginal cultures. And there's a new theory I came up with a few years ago. I have to also write this down. I need to move into a more retired teaching, because I have so many
Mhm.
things to write and so much to teach. And it's hard to fit it all in and see patients 4 days a week. But I call it the bolus buccinator theory of facial growth. And, I've collected, bits of information from various specialties. This human resting myofascial tone came from Al Massey, who's a professor emeritus, God willing,
Mhm.
he's still alive in university. Have you heard of human resting myofascial tone before,
I've
Lee?
heard of Massey. I've heard that name.
Massey. Oh, really? So
Yes.
he did his life's work on scoliosis. Okay.
Hmm.
And but he introduced the term HRMT, human resting myofascial tone, and he taught me about, passive tone and active tone. Maybe he didn't introduce it. He wrote about it in some papers. I don't know the entire history, but I stumbled on it, and I called him, and we started talking and corresponding. He's like 92 now. God willing, he's still around. I haven't spoken to him about a year. But and then he got me to understand, or looking at the enthesis. Have you heard the term enthesis? No. It's EN, the word thesis. And the enthesis is where a muscle or a ligament inserts into the bone. And typically you'll get ridges. Even this fake bone, there's a little
Hmm.
ridge over here. That's an enthesis.
Hmm.
And uh, bones and muscles attach. And when you use a lot of force on the bones, the enthesis gets big and thick. Okay. And when you don't use, it's small. So what I think is going on with jaw growth, or lack of it in our culture, is, and one myofunctional therapist, was telling me a few years back, don't have a kids eat pudding, pureed foods. They need to really chomp
Yeah.
and work the food. So it's not, and this is becoming common knowledge in dentistry, it's not just the hardness of the food, though, it's the bulkiness of the food. It's not using knives and forks. We overcook everything and it's soft. We should be food processing with our jaws.
Yes.
So when we do that, we blow out the buccinator muscle. So we chew up and down, with
Hmm.
not just the mandible moving up and down. Now it's the maxilla
Right.
too moving up and down. But the bolus of food moves left and right like the old-fashioned carriage of a typewriter.
Yes.
Okay.
Yes.
And so the tongue moves it laterally, and the cheek moves it back in. So you're like the video of like the
Yeah.
going
Yeah.
across the
Eating the
corn. I had
corn.
some
Yep.
corn last night, in fact, for dinner. But so if you have a big hook of flesh, and I picked up some pictures from my courses of like Eskimo babies with
Yeah.
chunks of flesh in their mouth,
Hmm.
working it, and they're working their jaws. And their entheses, which are pluripotential in children, they've got stem cells. Instead of just forming ligaments, you're going to get strong alveolar arches in the front too. It's not just the bolus; it's
Yep.
the orbicularis oris muscles and their insertion into the alveolar bone. A couple of months ago, I gave a lecture in Spain, but we spent some time I gave a lecture in Germany. We spent some time in Spain, and in Burgos, Spain, is this wonderful archaeologic museum, and they have these skulls, a couple of beautiful, pristine skulls of pre-Neanderthals, 400,000 years old,
Yes.
and they don't have this little dent in their chin. It's just solid, massive bone. And the space for the temporalis muscle here,
Hmm.
the Petrus plate or the temporal bone, it's deep, and the zygomatic arch is wide. That muscle was huge. It was like
Yes.
leg muscle, my
Right,
thigh
right.
muscle. So, and they were using force and processing food with all this force.
Yeah.
The So much force that there were ridges. I have pictures of this. There are ridges in the skull from the fibers of the temporalis muscle. They didn't
Yes.
cut things up or butcher things like we do. They did it all with their jaws, and they had tons of room for all their teeth.
Yep.
And it was a whole different system. We're so gracile, we're so fine, and into this milieu of humans with a pandemic of collapsed facial form comes modern dentistry, where we're just trying to adapt. Even, I joke with Josefian, my orthodontist, that he makes people look like cavemen and cave women. We make everything so much bigger, and he's expanded like you
Yeah.
can't imagine how much he's expanded some of my patients.
Mm-hmm.
And they breathe better because in the
Mm-hmm.
process of doing that, you expand. You have to be careful. There are certain things you can do. So corticotomies, you've heard of corticotomies
Yes.
in orthodontia, okay? So that can move the teeth out and expand to a certain extent. Rapid palatal
Mm.
expansion can expand more because you have to think about the buccinator muscle
Yeah.
and the pterygomandibular raphe. If you expand the alveolar arches into the buccinator space, people are going to bite their cheeks and not be comfortable.
Mm-hmm.
So you can only get so much expansion with corticotomy assisted orthodontia. So
Mm-hmm.
that's why you have to do other techniques. So to get a stable bite, there were basic 5 stable techniques that Pete Dawson talked about.
Mm-hmm.
Um, Reductive reshaping, additive reshaping, orthodontics, orthognathic surgery, or substitution occlusal splints. So now we have a gray area because you can do rapid palatal expansion to expand and make a stable bite, but also make a stable airway. You can do symphyseal distraction osteogenesis. You can fracture the mandible and put a tooth-borne distractor and slowly, move the jaw wider and wider. So rapid palatal, mandibular dyssymphyseal. You can do other forms of dyssymphyseal or distraction osteogenesis, or you can do full-blown orthognathic surgery.
Mm-hmm.
Now, I'm not a big fan of mandibular advancing devices because if you hold the jaw forward, you stretch the fascia out and then the jaw can't go back. I've
Mm-hmm.
got some patients who've had that done and they can't move their jaws back. And the condyle remodels and the eminence remodels and the disc disappears. And it's not a normal system anymore. It creates
Mm-hmm.
a whole lot of other problems. And some might suggest like a joint replacement, and I don't. I like to go with nature. I
Mm-hmm.
like to stabilize the bite into an orthotic, get them comfortable, and then, some kind of orthodontic. I mean, sometimes you can't just do an orthodontic solution. It has to be some kind of surgery because they're only touching on their front teeth and they've got these adapted jaw joints. So I think at that point you just do an orthodontic solution, or you do an orthodontic and a restorative solution, and you may need crowns on teeth. But I'm not a fan of joint replacement and things like
No.
that.
That-
So and especially if you can just get somebody happy and comfortable. I mean, that's the thing. I learned a long time ago from a patient in New York who is old, in her 80s. Somehow that's not seeming as old as it used to be, as I'm 68 now.
Right.
But how old are you now?
62.
Oh, you're an absolute baby at 62. I got 6 years on you. But her joints were broken down. I didn't know much about joints in those days. We're talking about 35 years ago or more. I've been practicing 42 years. It's crazy how long it goes. But I would equilibrate. I'd learned from Dawson in 1993.
Mm-hmm.
I did a lot of equilibration and I equilibrate her old gold crowns in the back and she'd feel better. And she'd say, "What I love about you, Jay, is you make me feel comfortable." Even then, I hadn't articulated love, but it was really learning from love and learning from my
Mm-hmm.
patients. And now I know my most important function as a dentist is to make people feel comfortable.
Mm-hmm.
And I do that, um, with making their bites comfortable and stable. So, have you heard of the polyvagal theory, Steve Porges?
Yes, I'm a huge fan.
Okay, so I had fun a couple of years ago, about 5, 6 years ago. I gave a lecture in Vienna,
Mm-hmm.
and Steve Porges also gave a lecture in Vienna about his polyvagal theory. I didn't know
Um,
about it at the time, so we talked, and I we chatted, and then after the lecture, we took a long stroll through the streets of Vienna, very romantic, and
mm-hmm.
then we found a sidewalk cafe, and we spoke for I don't know a couple of hours.
That's
And
amazing.
what I have my experience is, and he was helping put some neuropsychologic, uh, you know, diagnosis to it, was when I make people's bites comfortable, they feel good. Not only do their facial muscles relax, it's this whole body experience, which
Right.
is akin to this polyvagal
The
phenomenon.
feeling of safety.
Yes, yes, and they can close with even putting a freaking cotton pellet, excuse my language, I'm
Mhm.
from Brooklyn originally, between the teeth, they feel safe and the whole face relaxes.
Right.
And because they don't, because teeth have all these nerves that, what is it, 1,500 axons, 1,000 axons enter a tooth and divide into millions of branches into the dentin, and they're actually sensing the stress, the bending, the forces on the tooth from intradental, inside the tooth, mechanoreceptors.
Wow.
There are pain fibers in the teeth and so-called A beta mechanoreceptors. So you don't want to overload your teeth. If I took a fork and put it between your front teeth, just a fork, no food, and said, bite as hard as you can, are you going to bite hard?
No,
Why?
because it's gonna hurt.
Yeah, and you don't want to break your teeth. You're afraid. You're afraid of pain. And being afraid of pain in neurophysiologic terms is called a nociceptive reflex, pain
Hmm.
avoidance reflex. We avoid things. Why do you think these patients with condylar breakdown move forward and use their facial muscles? They don't want to break their back teeth. They don't want to hurt their back teeth. So in
Hmm.
order to get the task done of swallowing and breathing, they do funky things with their jaws. But
Hmm.
the teeth are drivers. It's like the blind man in the cane,
Hmm.
or woman. You're feeling around for what you need to do, and there's memory. So people know what their bad bite is all about,
Hmm.
and they know as soon as you let their teeth touch, they have to move their jaw this way, move their neck that way. And what I'm doing when I make an orthotic or even a jig or even a cotton pellet, I'm giving them a new reality. They don't have to remember that old point. It's not, they're safe. Just putting a little cushion of cotton between the teeth and they can open and close and their face will look like this,
Yeah.
really passive. Okay, they're not afraid. They know they're safe and they can relax, and their whole body relaxes to a certain extent. The more time you give somebody like that in an appliance, the better. I like your hands behind you holding your
Oh,
patient,
that's my
your
that's
logo.
identity.
Right. No, I know, I know. I mean, it's just, yes, you're doing the same thing as me. I mean,
Yeah.
you're starting with this tooth thing, and then it becomes the whole person, the whole body. I mean, we're just diving into our own, Alice in Wonderland, holes, or and we're coming up with similar but different, aspects of that. I neurophysiology, biomechanics in my courses. I have engineering analyses of stress in teeth. I have my first theory of intradental mechanoreception. Now, bending stresses and strains cause tubule fluids in the odontoblastic tubules to be stressed, and you can tell when your tooth's like about to be broken because the nerves inside the dentin are saying, hey, shut down the muscles because, I don't want to break this tooth. I want it to last for me to survive. And
Right.
so we have all these strategies and all these behaviors. And yeah, we use the temporomandibular joints, but we also use the atlanto-occipital joints. We also have overall body posture dealing with things. I'm a keynote speaker in a course in Italy, 3-day course in September, and it's fascia tensegrity, a whole bunch of osteopathic physicians and physical therapists lecturing on the second and third day. I'm the first day, just to show how the teeth tie into all of other aspects of the body. One neurokinetic, David Weinstein, neurokinetic therapist, I met him through Facebook. He teaches neurokinetic therapists around the world. And he said, if you look up and clench and feel your pelvis, you'll notice it lifts up. I mean, tensegrity structures, we're connected from head to toe. You have to feel the crest. It's just a little bit. So maybe you need to be standing versus sitting in the chair. But we're all connected. I have no doubt that that's true. And, you know, the teeth drive posture. Now, I don't know all about that because
Hmm.
I'm just a dentist, but I think all dentists need to understand the chewing system like I understand it. Uh, that teeth are neural bulbs, that fascia positions the jaws. there's active muscle tone, that the chewing involves the TMJs and the AOJs, and really understanding that in great depth is really critical. And then understanding how to manipulate clinical methods, making an anterior jig, a Lucia jig, so that patients relax, using it to put a bite registration between the teeth to capture the index of the upper and lower jaw together, using a face bow or a facial plane analyzer to mount models to simulate how the patient chews, how their teeth collide when their jaws are centered. I mean, that should be all part of what general dentistry is about. And then techniques to do what I did yesterday in an 8-hour appointment, bond 10 teeth and do it with everything centered so that they write sticky notes. I used to stick my tongue between my teeth. Now I've got all these teeth touching, and all of the sensory signals coming from all of those teeth are harmonious with her posture. They're not forcing her to use her tongue or overuse her tongue. So a Lucia jig creates one tooth contact. It's kind of like using one finger to play the piano. And as you start adding more tooth contacts in, you're adding more musical notes. One of my courses, sometimes I use a Mozart Amadeus, and then he played this piece for the emperor, and the emperor was saying that it's very nice, it's very interesting, Mozart, but there are too many notes. The human brain can only comprehend so many notes. Just like there's only so much that the nervous system can process with teeth touching in aberrant ways. And so patients with occlusal, with bad bites, are biting, and they have to do it so slowly and carefully because, I've got to shift a little here and shift here, and it's all subconscious. And then when you create a system of chewing, either with a jig or a splint, or when you fix the teeth like I did yesterday, they open and close fast and hard, and they're well resisted, and they don't need to use their facial muscles, and they didn't or overuse their facial muscles, and they don't need to overuse their tongue. So that knowledge is what gets patients comfortable and out of pain. It's also that knowledge that forces the dentist to understand, how do you restore teeth to be in harmony with that so you don't always need an appliance? And that's where it gets to be a little bit more complicated, but not that complicated. There's a thing we all do a little bit of in dental school called a diagnostic wax up. And nowadays we can do it digitally. But so after you're done and the patient is in phase 1 treatment and the patient is stable in a splint, then you see, do we want to go to stage 2, or do you want to just use a splint, part-time or full-time for years to come or for life? But if you want to go to stage 2, then you have to say, well, the jaws are closing. It's an open bite, except it only touches on these 2 teeth. And, can I conservatively get all the teeth to touch? Or do I need to do orthodontia to expand things and move things around? And how much restorative dentistry will I need afterwards? So stage 1 treatment for almost all of my patients is, basic, oral hygiene instruction, and nutrition counseling, cleanings, periodontal extra cleanings if they need it, and caries control, remediation. You get rid of all that baseline stuff, the site work, and then you you do a splint, and you get the bite stable and get them comfortable. Sometimes the splint's the first thing you do because the patients are coming to me in pain, and you get them really comfy, and you deal with all these little things, and you say, well, do you want to have orthodontia? But my orthodontist is up in Seattle. It's 3 hours away from me. And there are other orthodontists that I know of around the country, and actually in other countries as well. I'm fairly well connected to the globe at this point through Facebook. Ultimately, a lot of it was that, although my first Germany lecture was separate. But you have to do an orthodontic solution to get the teeth to meet conservative. If you've got a lot of crooked teeth, do you really just want to bond and add to? Now, I can make teeth like in an older person that are a little crooked, a little bit off. We can do conservative, functional composite buildup sometimes to make a stable bite. I just recently did a full mouth case because she didn't want to do orthodontia. She had a bunch of crowns in her mouth, and I did 27 crowns. And the process was seamless. So I made her comfortable 7 or 8 years ago in a splint. She wore it full time for 7, 8 years. She's now 69 or something. And this year I finished treatment because at the beginning of the year or into last year, she decided, I don't want to do braces. I just want to have my teeth fixed and I want a stable bite so I don't need to wear the splint all the time. So I did what I do a lot. If I'm going to do a big case like that, I took her splint. I measured her vertical dimension of her splint, and she's super comfortable in the splint, and that was the right vertical dimension to do her treatment. And if you took the splint out and looked at the gap, there's a big gap between the upper and lower teeth,
Mm-hmm.
but that's okay. And so I cut her splint into 3 pieces and did bite registration in back and bite registration in front. And then I spent 2.5 days and I prepared her teeth for crowns. And the crowns were made on a diagnostic wax up from that index bite from her old splint. And I put the provisionals in the whole mouth. That's the only time I have to do it all at once. And I asked her, how does it feel when you bite? She said, well, it feels just like my splint. And that's great. I did this in another case. He had the same comment. Just feels just like my splint. And then we do impressions for the upper 12 teeth, and I make permanent crowns in the upper 12 teeth with beautiful anatomically correct posterior crowns. And the patient said, well, it feels just like my splint
Mm-hmm.
with the provisionals in. And because I'm old and I don't want to work too hard, I restored her lower posterior and then her upper posterior. And the upper posterior just went in a couple of weeks ago. And how does it feel? Just like my splint. And I hardly do any occlusal correction if I'm precise with all of this. Though that's like one end of the spectrum. The other end is just using the splint. And in the middle, you can do cases, take care of patients with orthodontia and other expansive techniques. Now, in a younger person, you want to be as conservative as possible. And most of my work is in stabilizing occlusions when I actually get to the teeth is to do functional composite buildup. So you do a diagnostic wax up of it, silicone matrix, you injection mold composite onto etch prime bonded teeth, use Teflon tape so you don't glue the teeth together, and you trim them up, you make beautiful teeth. And that's what took me, 8 hours yesterday on one patient for 10 teeth. So, sometimes you can do them in a half an hour too. Some teeth are more complicated. And if you're doing molars, it's a pain in the neck to overlay the entire surface with composite, but it can be done. And the stuff lasts when the function is correct.
Right, when they're not bruxing.
Right. And they don't brux anymore. I mean, I've had so many patients, bruxing. They don't brux anymore. They don't grind, they don't clench. You're changing the behavior because you're changing the tactile cues and you're giving them a verticalized occlusion. So these are Bob Lee and bioaesthetics. Have you heard of OBI or orognathtic bioaesthetics?
No.
You've heard of Dawson, yes?
Yes, I've heard of DOS.
So Pete Dawson was a dear friend, pen pal for years, and he quotes me in his book. And so here's just a nice 43-year-old with a really perfect bite. And I've got a bunch of these 3D printed, and all I do is I copy this. Okay. And Bob Lee, who's the philosophic founder of OBI or orognathtic bioaesthetics, just looked at unworn tooth forms. He looked at patients with their teeth intact and in great shape into their 80s and 90s, and he saw there was a certain amount of length and overlap and sharp, unworn tooth forms. Now, Pete Dawson, I loved him dearly, and he taught me so much, but he was afraid to make teeth too long or open the vertical dimension. It's no problem to open the vertical dimension. You just have to have human resting myofascial tone. All the jaws have to close and open in a relaxed way. And then you can have, but that's later. And I will make my occlusal splints with steep anterior guidance, and patients will love them. The level of comfort just goes up and up and up when you make the splint a trial prosthesis. It's like a full mouth reconstruction and a hunk of plastic. And you invest time and you have to charge some money for it. And but it's not that expensive, and it's much cheaper than doing a full mouth reconstruction, and it's much less invasive. And I'm fine with leaving patients with splints for years to come if they don't, choose to move forward with other treatment. Now, most dentists think that they have to fix teeth. They have to go and do this and that. I mean, you can do conformative dentistry and just fix teeth and get patients' gums pristine, but they need to have a life preserver. They need to have a really well-adjusted occlusal splint to protect them from adverse forces, which may happen at night. Now, the night thing is a sleep thing too, potentially, and that's because, the terms are all a little bit wrong. Sleep disordered breathing or obstructive sleep apnea is basically airway obstruction, whether you're sleeping or you're awake.
Right.
And sleep disordered breathing or I don't breathing disordered sleep, or there's a lot of
How about
semantics, and
just
this
breathing
stuff's going on.
disorder?
Right,
Disordered breathing.
right. And most of our disorders are because it's like, people are trying to breathe through a straw instead of breathe through, a large tube. If you, and so many patients, you'll see patients that are skeletal class 2s. And so the hyoid bone and the chin are intimately related. So if they're skeletal class 2, the jaw's back, the hyoid bone is back, and the airway is small.
Mm-hmm.
And if you need to do BSSO, mandibular advancement surgery, you're going to pull the hoop of the hyoid bone forward, and you're going to make the airway bigger. And so that's one way that, I mean, Joseph Yosefian with his teledontics, he cures sleep apnea in many cases. He's got like
Yes.
case series, like 80 or 100 cases. And you do it in a variety of ways. And that's why the rapid palate expansion is important. However, there are practitioners practicing expansive orthodontia, but they aren't creating a really good bite at the end of the day, a nathological bite. I mean, that's the thing. If you don't create a stable bite when you're done with an orthodontic solution or a surgical solution, you're going to have the teeth break down and the relationship is going to change. So if patients are forced to bite and move their mandibles, like forward posture, or move the jaws to the left or right, they're going to cause tension in the joint, and the fascia and the joint is going to become inflamed. And a situation is going to be created where the heads of the condyles can erode. You don't want inflammation in the joints. My job is to take patients who have had, discomfort, jaw pain, facial pain, condylar resorption, and create a situation where they're just chewing and functioning and opening and closing. There's no traction on the joint. There's no inflammation. The fascia, which is like, the flesh under the skin of a chicken, all these fibers. And there's a wonderful book. We don't have it here. It's at home. Strolling Through Fascia by a Frenchman. And there are videos that come with the book, and you just take an endoscope and you look at all these strings of fascia. You want the fascia around the disc of the TMJ to just settle back and to heal and stop being torn and recover some structure. And that's what you do when you support a patient in a properly adjusted occlusal splint. So you can create a situation where, there's just harmony in the joints, and you give the joint a chance to heal. And then you have this wonky relationship where the upper and lower teeth, don't necessarily, they don't relate very well. I mean, they're like that. And then what do you have to do to make it right? Well, you can put a wedge of plastic in and make them comfortable. It looks crazy, but they're comfortable in it. They can't close their lips really easily, which is another little problem, but at least they don't have this pain and headache thing going on. And it's hard to speak, but eventually you can figure out how to speak with it. But it's just revealing a skeletal problem. Your right leg is 6 inches shorter than your left. So instead of destroying your hips, you put a lift in your shoe to make you walk level. So that's, a stage of treatment. And then, if somebody wants, they could have maybe some distraction osteogenesis and make a leg longer to compensate or something like that. But, there are two different questions and two different stages of treatment. One is just getting comfort. And when you get comfort in your patients, you get them to trust you, and you become a leader, and one can develop a different kind of a practice. You can call it a compassion-centered practice, but it's doing medicine, dentistry, like I think most of us thought we should, for helping people. You know,
Hmm.
not everybody. When I was right out of dental school, I was an instructor at NYU Dental School where I went to school, and there was a kid, a student, who in his cubicle he had a poster. They each had their own cubicle for treatment
Hmm.
in the third and fourth years, and the poster had a garage for 12 cars and each exotic car in front of it. And the caption was the value of higher education, you know? And so this kid is going to become a dentist for all the wrong reasons to make money,
Hmm.
you know? And I can tell you after, lost my mom last year, you don't take anything with you.
Right.
All this physical stuff is totally meaningless. The thing that's meaningful is the relationships you build. It's the compassion with your patients. It's the love you build in your practice. All my patients are aware that I'm going to be pulling out of practice next year at some point, probably in the beginning of the year, and I'm really trying to find somebody to mentor and teach and take over because I just can't keep doing this forever. I need to teach more. I need to write more. It's only, 68, how many more 15, 20 years of intelligent being
Hmm.
left? I don't know. Maybe, who knows? But you know, uh, you can help people if you have the knowledge, and that's the whole point of this. And I can pass things off. I've got, things written in textbooks and journal articles, and something will be remembered. And other than, I certainly don't remember cars. You go, I bike home, I bike to work a lot, and uh, you pass cars, and it's like, wow, that was a really fancy car. Now it's a beat up vehicle
Right.
that a homeless person is using. You know, um, there's no value in that car. It's a useful tool, uh, and it becomes, and what was the embodied energy in that car that had to be made, and how much pollution was made, and how big a hole was dug in the ground because, people are acquiring physical things, and that's their goal. So I applaud you for bringing this discussion out. And I'm sorry if I bored you with all these technical aspects of it, but Dave Carson would be a good one to talk to also. He's at OHSU. I can get you his contact information if you want, just to talk about empathy. He gives courses on empathy, and
Hmm.
I've spoken 3 times now to the OHSU, Oregon Health Science University residents, yeah, basically about the occlusion as I see it, to a certain extent. And Dave does his great job with the empathy training of the young dentists, and it's just really so important. But I do get students in and dentists, and they're trapped in this HMO PPO model of industrial care where they're forced to see a zillion patients a day. The last
Hmm.
couple of years since COVID, my staff didn't come back and I changed my practice model. It's still 4 days a week, Monday through Thursday, but I schedule half-hour breaks between patients. And now I only have one assistant, and I don't care if I answer the phone all the time. And so I see fewer patients. So I basically do 2.5 days and 4 days or something like that.
Hmm.
And it's mellow, and I don't guess I care if I get a new patient or not. I care if I can help somebody, but I don't want to be overloaded or overworked.
Hmm.
And technically, I'm probably having my best year ever this year, business-wise, but I'm not trying. I'm
Right.
just doing good work. I'm helping solving problems that other people can solve. And you don't need to run around like a hamster in a cage to do that. You can have absolute rewarding work and a rewarding life and a rewarding life balance. And I'm taking 40 days a year off from my 4 days to give lectures, or I had a sick mother and mother-in-law to care for before she passed. And, we all are going to go through that at one point or another. And, there's so many paths you can take. When I graduated school, the standard was the private fee-for-service practice. And then now I'm an absolute rarity. You
Oh,
have
yeah, absolutely.
and we help, you know, patients get their own insurance. I don't even do electronic billing because that whole system requires so much staff attention. I just have my computer assistant print up a form for a patient, and they
Hmm.
hand it to themselves. And we do still get stuck helping them with their insurance periodically, but the insurance isn't there to get a patient healthy. The insurance is there to make the insurance companies rich.
Right, to make money for their stockholders. Yep.
Yeah, and pay their CEOs exorbitant
Yes,
fees,
ridiculous amount.
and the whole healthcare system. As I'm transitioning to I did Medicare and
Right.
and all that stuff, and now like long-term care, and it's all these questions you have to look at because our healthcare system is so messed up.
Yeah, it really is.
It's really awful. Anyway, so you're over there in Rochester, New York.
Yep,
I
upstate.
visited. I'm from New York, and I went to Union College in Schenectady, New York, which is about
Hmm.
2.5 hours from you, or something like that, or further.
I think it's a little further, more like 4.
Is it that far? New York's a bigger state than I remember.
Oh,
I
yeah.
I went to Rochester once when I was like 10 for something. It was the first time I ever flew on an airplane from New York, from Long Island or something. So, but I've been to Buffalo. You're about an hour from Buffalo or something
Yep,
like that.
60
Yeah,
miles.
yeah,
And
yeah.
yeah,
So
I've
that's
given my course several times for the University of Buffalo CE program.
what is your course?
It's called Roots of Dental Trauma.
Hmm.
And, I talk about what I said in the beginning. And, I try to educate these dentists on a little bit of this, a little bit of that. I talk about polyvagal theory. I talk about the neurobiology of trauma. And I talk about, oral movements based in airway protection and retained oral reflexes. And these are the things that, you know, that drive dental professionals crazy. And they label these patients, rude and demanding and uncooperative when what they're just trying to survive. They're just trying to get through that appointment and breathe. So
Hmm.
what I want to do is, introduce these dentists to these concepts so that they can hopefully, look into them more and to try to get them to understand what's going on in the brain chemistry, the body chemistry of these people. And certainly, so I'm listening to you, and in myofunctional circles, okay, we talk a lot about form and function, but I have to say that the impression that I get is that the teeth almost don't matter, that it's all the muscles. So to hear you talk about the teeth in that, that it's like that it starts with the teeth is almost antithetical to
I know, I
what
know.
I've come to understand. So I'm like, this guy's like spouting heresy. And so it's not what we are educated in.
Right. Well, the fastest reflexes in the body are corneal blink reflexes, and the second fastest are tooth reflexes. Um, Teeth drive muscles. Okay,
Right.
and it's just in the TMD circles for years they were talking about it's all the muscles. That's nonsense. It's what you have to have an action potential to drive a muscle. So you have to have a neurologic phenomenon to drive a muscle. And in the nervous system, that's why I did I go down rabbit holes. And so I went
Hmm.
down, 6 years of neurophysiology research, and I'm still doing it. I mean, my dear
Hmm.
friend Willie Dong just published a paper a couple of days ago in the Journal of Neurophysiology on sensory motor integration, finding specific cells in the brain for that. And I'm still in that world. But dentists tend to oversimplify everything, you
Yeah.
know, and in reality, I don't know everything, and I don't have to know everything. You don't have to know everything. But when you get a flavor, you get a feeling for how something's basically working, and that
Hmm.
feeling has to be plastic as you learn new things too.
Yeah.
So that's important. Now, one of the things you said about the problem patient. I love getting problem patients,
Me too.
people, because you can see what the problem is. So PA, as a hygienist, have you ever taken a full set of x-rays?
Of course.
And there are all those patients that you can't get that sensor down under the tongue, right? You know,
Right.
and the patients are just in a panic, right?
Right,
And because your tongue is being put, the tongue's being pushed into the airway because there's not enough
right.
room for the tongue. Patients don't have big tongues. They have small jaws.
Yes,
And if they have big jaws, there's no problem. And
right,
so it's just your first sign that this is a person with an airway problem, and they gag like crazy. Why are they gagging? Because they don't have enough room
right.
there.
They can't breathe. And I've developed a breath coaching technique to help patients get through x-rays, and it works 9 times out of 10.
I'm sure it does.
And patients are like, what? This one
That's
lady
great.
cried. This 76-year-old woman cried after I got a bite wing and she didn't gag. She lived all those years thinking she was a bad dental patient.
Mhm.
And I'm
You
like,
know,
okay, we're done.
it's great you're doing that. I mean, I've done uh, similar things to a certain extent with patients, different ways of suggesting. One of my patients was a hypnotherapist,
Mm-hmm.
and you know, I did a bunch of work on him years ago. He retired and moved back to England, and one day he's in the dental chair, and his hand's doing this, and his name was Jeffrey, and and his eyes are closed. And usually I actually like patients to see what's happening, but Jeffrey was fine. I said, "Are you okay, Jeffrey?" He said, "Sure, yeah, I'm fine." "Well, what are you doing?" He said, "I'm fishing." So, so when I'm doing all this dental work, he's fishing.
Right.
So, so one of the things I do because of that is if I'm giving an injection, especially with a person who's fearful,
Mm-hmm.
is I'll show them what I'm gonna do with the needle
Mm-hmm.
cap on, and I'll touch the area, and I'll say, why don't you like lift up your left foot and wiggle your right big toe and your left in, and you get them thinking about and then now switch or just some
Mm-hmm.
so if you can, if you can change the focus, that's a trick,
Right.
it's not necessarily a coaching thing, but the brain can only focus on one thing at a time. And if
Mm-hmm.
they're juggling different things, then there's not so much of a focus on it. And so, giving injections is one, uh, breakthrough thing with patients.
Mm-hmm.
But, sure, if you can, coaching with impressions, how many thousands of
Right.
impressions I've taken, and some
Right.
paper gag or not. I mean, this is maybe not the best coaching technique, but it's just like, you know, you explain what's going to happen, and you just say, you're
Yeah.
not going to gag. You're
Yeah.
not going to
The power
gag.
of
You're
suggestion.
not
Yes.
going to do it. And it's also this like taking command and listening to someone, that urge is overlying. So
Mm-hmm.
you can overcome that in certain individuals. And it's not perfect, but you're right. I mean, I'm would be eager to hear your techniques, uh, to coach people through all of this stuff, because and it's not in the dental school curriculum, that's for
No.
sure.
Gagging is about the in-breath.
Mhm.
If you
Okay.
are breathing out or you're holding your breath, you will not gag.
Hmm.
So I have the patient nasal breathe, hold your breath,
Yes.
place the sensor. As I go to press the button, breathe out, breathe out, breathe out, breathe out, breathe out.
Huh. Cool.
Nine
That's
times out
great.
of 10.
Uh-huh. That's great. Have you written that down somewhere?
Have I written it down somewhere? No, but I might have written about it in a blog, but you know, I talk about it, but I haven't really written it down.
When should you write it up in an article for dental hygiene or something like that?
Okay.
It's work, but do it.
Well, I've been published. I might have, now that I think about it. No, I wrote an article about chewing, but I didn't talk about that.
Talk about that. It's important. I mean, all that stuff is important. You've got a zillion techniques. You're like me. You've been thinking about this stuff for a long time, and you
Mm-hmm.
come up with solutions, you know, and you're doing a good job. I mean, all these podcasts are great. We have to share, and of course, we have to get people who want to pay attention long enough to listen.
Right.
And their attention spans are so
So, yes.
limited in our culture. But yeah. So PA's airway, yeah, and gagging and tongue size, all that is airway. And all of that is, we're not like those skulls I saw in Burgos, Spain, in the
Yes.
archaeological museum. And they didn't have these problems.
No, they had
And that,
45 millimeter pallets.
yeah. They and you know what the chief cause of death in prehistoric times was? Take a
Probably
guess.
trauma, right? Being attacked by something,
Falling out of trees.
falling out, falling out of trees. Yeah, falling on your head.
They'd have the predator below, and they'd be hanging out in the tree, and
Yeah.
they'd fall asleep, and they'd fall out, and they'd die. You know, so I read it somewhere. But I go find the citation if you want to quote it directly. But you know, it's,
I have often believed that early humans felt better than we do. They were
I
using
get
their bodies the way your body
yes.
is designed to be used. The reason that modern humans are ill is because we're living against how we're wired.
Totally, totally against. This is so totally unphysiologic. If if we go backpacking, all of a sudden we feel better physically. I look at, I don't know if you can see, in downtown. I moved from New York to get away from things, and
Right
Oregon
now
is
you're
a
on.
beautiful country here, but I'm in the heart of the city on
Now
the
you're in a
11th
city
floor,
again.
and there's a 35-story building that just went up. That's the Ritz-Carlton across the street, and it's so urban. But you even walking through the halls or walking down the street, there's all these sensory experiences which are not normal.
Mhm.
There were a series of books by Daniel Quinn, Ishmael, the story of B, and I read them a while ago. But the first chapter or introduction of the first book, this guy walks into a room and there's a gorilla in the room, and the gorilla's really a sage. And the words of the gorilla that I remembered were, "We teach our children to dance to the drumbeat of mother culture." And that's so true. My daughter was a water birth at home in Connecticut, a little house built in 1780, and peacefully in the water. As soon as she came out of the water, she hunted to breastfeed.
Mhm.
And then when we had to come out of the water and had to stop breastfeeding, she just like crying, that was, and it
Mhm.
was like her voice was heard for the first time. And you know, from that point forward, we had to teach her how to dance to the beat of mother culture, how to fit into all the cultural things. Now we tried to hem and haw a little bit by, she went through a Waldorf education, which
Mhm.
in the beginning, before she got into the mainstream, and multimodal learning, and there's all these other aspects of it. But you've got to figure out how to navigate all of this, and
Yeah.
you know, and and into that comes dentistry, where you're invading all that personal space. And I mean, I'm a mush, and I try to do everything with love, and I know patients are anxious, and
Mhm.
the patient from Florida, I'm like, you know I gave her a hug, and I know this is hard. I know you've been through the mill, and
Yeah.
you've been searching for answers for years,
Years and years.
and not getting it, and things still fall apart. And you've been a good girl. You've been brushing and flossing and eating
Mhm.
whole foods, and still everything is falling apart because the the doctors, the dentists aren't really fulfilling all of your needs. They
Right.
don't understand what's going on, and
Yeah.
so I don't know. This is I'm sure a long,
I know.
you know,
And I actually have an online client too. But I wanted to say, one of my favorite slides in my lecture is a picture of the back of the throat alongside a picture of the Taj Mahal and a chapel and the Cathedral de Notre Dame.
uh-huh.
And it's that you, right? It's
Hmm.
sacred. That you, sacred spaces have that you shape. And so does the back of the mouth. This is
Hmm.
sacred.
Uh-huh.
Okay. And
Okay.
we go in there like it's a freaking construction zone. And
Yes.
it's not.
No, no,
It's
no.
not. And I
It's,
think you get that.
oh yeah. Yeah. I mean, the preponderance of our senses are in the head and face.
Yes.
We address the whole world this way. And I'll leave you with one last esoteric thought. I vibrated teeth in my research, and really all of life is vibrations. Everything we know or experience has come to us in one form of vibration or another. I mean, I've discovered that teeth are vibration encoding sensors. The most sensitive frequency for feeling teeth is 55 hertz. And I just got some tuning forks, and you can barely hear 55 hertz, but if you put it on your tooth,
You can feel it.
it's so intense. just, I think you can use them for pulp vitality testing. It would be a hell of a lot less invasive than electric pulp testing.
Yeah.
But the most sensitive frequency for audition for hearing is 2000 hertz. The most sensitive frequency for touch with the skin, the Pacinian-Meissner system, is 350 hertz. The most sensitive frequency for vision is yellow, 550 trillion hertz. Everything that's been inputted into our brain in these entities we call cortical maps that we reference for the rest of our life is from vibrations. Children learning by putting things in their mouth, they're programming their brains, and you're helping to reprogram brains. And even the teaching is reprogramming, to teaching to professionals or teaching to patients and all of that. So yeah, these are my new
I like
tools.
that a lot.
So anyway, so great.
Thank you. Thank
Thank
you
you
so much.
Thanks for having me. And this should be an interesting, hopefully an interesting mishmash of information.
I think so. A lot of information, a lot of education, but also, some connection there. And that's what I'm after.
Thank you so much for being you. Okay.
You're welcome. Thank you.
Thank you, Elizabeth. So is it Liz or Beth,
Beth.
or Elizabeth?
Beth.
So I should call you Beth. Okay.
Yes,
I
please do.
tend to use the formal. So all right, until we meet again. All
Yes,
right.
I hope I do. I want to meet you in person and give you a big hug.
I will give you a big hug too. I'm a big hugger as well. All right.
Yay.
Have a great day.
You too.
Enjoy your
Thank
next
you.
client. Okay.
Okay,
Bye-bye now.
thanks. Bye.
Bye-bye.